Saturday afternoon, October 21st, and you can be a major participant if you indicate your interest to your SUPs. Okay. Any other issues, questions, administrative business to handle at this point? Okay, well, let's turn our attention to the reasons for the U.S.'s excessive per capita and excessive percent of GDP healthcare expenditures. Shi and Singh, pages 468, 469, as I indicated at the end of last class, have important information about this and a very powerful graphic. There's a very detailed table on page 468, a powerful graphic on page 469, which shows that healthcare costs are inflating everywhere: Netherlands, Canada, France, Germany, Japan, Sweden, etc. As you can see by comparing the two bars, which represent where things were in 1985 and where they were in 2009. But the U.S. is much greater. It starts at a higher point and it goes up more quickly, as you can see by the most extreme right dark blue bar. We can pursue this further through the handout. So turn to the handout, which everyone hopefully will have. Okay, where do the handouts stop? There are a few hands of people who didn't get them. Who has a bunch of handouts?
I do.
Who? Okay, pass them. One up there. Give this gentleman a handout. A couple over here. Okay, we had a spotty handout distribution. I'll wait just a second to make sure that everyone has it. Okay, there are copies going around. Good. On the first page of the handout, you see the usual information. This is now, we just turned it on its side. So instead of the U.S. bar being way up and on the right, it's way up on the top. And it's up very dramatically. This is per capita expenditures. This is slightly more recent data from 2012, same basic source, the OECD, which is that group of most advanced economically sophisticated countries. The U.S., by those measures, had a per capita expenditure for healthcare of $82.33, and that contrasted dramatically to other countries, which you can see going down. Norway, Switzerland, Netherlands were closest, but far behind. A better way to see that, I think, is to turn over that handout to look at this plot of per capita income versus the expenditure on healthcare. So what you have on the vertical axis is the spending on healthcare per capita, and what you have along the, that was the vertical axis, what you have along the horizontal axis is the per capita income of those countries. And so you see that it's a positive correlation, as per capita income generally, as the economy's strength increases, the amount that that country has available and can afford to and politically is guided to spend on healthcare increases in this positive correlation. The line in the middle, the solid line in the middle, is the direct plot of that simple positive correlation. Whatever the coefficient is, that defines the angle of tilt, okay? And you can see that it's a pretty directly linear relationship. All those little circles represent specific countries. There are a great many countries that follow along almost exactly on that line, or are very little separated from it. So you have the countries which are sort of really on the line, or just a smidgen off the line, and those which are captured in the shaded area, which means a sort of a standard, I don't even know if it's a standard deviation, but some variance from what the simple linear plot would indicate. And then you have a few countries which are a little farther away, but all of the countries, with one major exception, are contained within the dotted lines. So this means that there are variations. Countries make decisions on the basis of political priorities, change of government, whatever, and actually invest more or less than this prediction would indicate they should if you made it a straight, absolute linear relationship between income per capita and investment in health per capita. For example, if you made the direct plot of what Australia should invest based on this data, it should be 38.52. In fact, when the data were collected, it invested slightly less than that, 36.70. It's not a significant difference. They'll be very close to that line, but it indicates that there were some political choices and priorities. A somewhat greater difference would be in Denmark, interestingly. The prediction was that Denmark, given its per capita income, should spend 38.97, which is quite a bit lower than 4,000 as a measure. But Denmark actually spent in that year 4,385 per capita, quite a bit more by comparison. Why? Don't know exactly. That's a question worth exploring. Probably has a lot to do with Denmark's political situation, its social values, its notion that we really ought to invest more in healthcare and less in some other sectors. Denmark doesn't have a major military establishment to support, whatever. So Denmark has chosen to invest its resources greater than this linear relationship. And you can go through the list. I have a list of the top 50 or so countries. Here's another example that might be interesting and curious for many, but I think there may be some explanations. Israel is, on the basis of this relationship, predicted to spend $28.45 per capita in healthcare. It actually spends quite a significant amount less than that, $21.65. And that may have something to do with all sorts of complex Israeli political realities, such as its Palestinian population, which is not granted citizenship, or even those who are Israeli citizens are given second-class rights, and that might also affect their access to health care. There are all sorts of things in the reality of political Israel which don't fit its image and its projection and its public relations, and these numbers may capture that. That's one possible explanation. I don't really know. But however countries may vary from their predictions, no country varies from what it should spend on health care based on per capita income than the United States, which spends way, way more. It is literally an outlier. Outlier has two meanings. Outlier in statistics has a specific technical meaning. An outlier, as we use it in general conversation, means it's off the norm, it's out in left field, it's weird, etc. Well, from the graph on the first page of the handout, the U.S. is an outlier both statistically, it's outside these plot lines, and, of course, we know already, figuratively, it is way out of kilter with all the rest of it. But why? This is reasserting, revisiting what we have already been talking about. But now the question becomes why. There is a discussion in Shi and Singh on pages 471 to 476, which they label reasons for cost escalation. And as they explain their reasons, they're trying to figure this out too, and this discussion follows the graphics just a few pages before in Shi and Singh, so we're really on the same page here. They look at this as an international comparative phenomenon. There is frequent reference to the peculiarities, oddities of the U.S. situation. But I want to take Shi and Singh and focus their discussion and their arguments and their data specifically on a closely related but slightly different question. Not why there is general cost escalation in healthcare. I said again, and will repeat, that there's cost escalation in every healthcare system that we know about. And the reasons that they give, which I summarize here in a table that they actually publish on a list on page 472 on the top of the page. You'll see modified their list a little bit. They offer these explanations, and then under each explanation give a paragraph or two or three to elaborate to make sure we understand why there is cost escalation generally in healthcare systems. I want to take that question and refocus it to the following. Why is the U.S. uniquely the outlier? why do the factors which explain cost escalation and apply everywhere apply in a peculiar way to the United States? In other words, if all these factors are relevant to explaining why Denmark and Israel and wherever have cost escalation, why is it the United States has such excessive costs and excessive rates of escalation? Are there some factors in this list which are peculiar to the United States and not universally applicable, not generic, as may be some? So in other words, we can take this list and we could parse it into those factors which explain the uniqueness of the U.S. situation and separate those from those factors which explain general, universal cost escalation. Well, let's start working on this list then. And the first thing I want to do is take one of the listed factors, this is from Shi and Singh, off the list. Third-party reimbursement, third-party payment. Why do I want to take it off the list? Because my refocus question is, what is it about the United States that is specific to it that will explain the U.S.'s unique situation? And a factor like third-party payment, which of course is very widespread in the United States, is also widespread everywhere. It's a universal factor. Even in those healthcare systems that provide either salaried healthcare or healthcare that's delivered by physicians who are paid on a per capita basis, the number of people in their practice times a certain number equals what kind of income they receive from the government. Countries like the UK, like Sweden, some others, even in those countries which do not have a third-party insurance reimbursement mechanism as the major financial arrangement, do use third-party mechanisms to pay for things like hospitalization, drugs, and other expenses which are these days outdistancing physician costs as a major contributor to healthcare costs. So since it's a truly universal factor, it's everywhere, it can't be something that will help us understand any kind of unique appearance. That the United States has third-party reimbursement, so does every place else. But every place else is able to do a better job at cost containment. So how important can third-party reimbursement be? If it works okay in Denmark, and works okay in France, and works okay in Czechoslovakia, why doesn't it work okay in the United States? It cannot be a factor that really is going to give us a lot of distance and insight. But what about some of the others? Well, I've also added a factor that's not on their list, which I put here in brackets. And though they allude to it in a couple of places, they don't discuss it explicitly. They don't include it in their table on page 472. But it comes up almost immediately in every conversation that I've had over my many years of teaching and debate and so on about the U.S. healthcare system and its comparison to others. Well, of course the U.S. is more expensive because we have such a heterogeneous population. We have such major racial and ethnic issues and so on, and that creates many disparities and so on, whereas all these other countries that you're comparing us to are much more homogeneous, if not completely homogeneous. Think, for example, in your mind's eye, of all those blonde, blue-eyed Swedes, for example. That's not exactly an accurate picture of Sweden, but it's certainly a common image. In fact, what we have to come to terms with is, and that's why I've added here, that yes, the U.S. has an extraordinarily heterogeneous population, and that heterogeneous population creates some major issues and contributes very significantly to our strange social system and our strange health system. There's no doubt about that. But it's not so different, and in fact it's increasingly not so different in Europe. There are many countries that have growingly heterogeneous populations, and in fact have major political battles about those that you've probably begun to read about. So countries like For example, Germany, England, France, and even Sweden, to some extent, the Scandinavian countries, are countries which have a growing heterogeneous population. Think of the attempted absorption of Syrian refugees in Germany and the problems it created, and in other countries too. Think of the rise and of influence of right-wing parties, neo-fascist parties in France, neo-Nazi parties, a neo-Nazi party in Germany that scared the bejesus out of Angela Merkel, who, though she was re-elected Chancellor of Germany, she nonetheless had to face for the first time a major presence in German Reichstag Parliament of a major neo-Nazi party, which Germany thought it seen the last of. Yes, there are kooky groups, but this is a group large enough to get a significant number of seats in the representative body. And what do these parties stand for? Just like a considerable part of our right-wing, alt-right, as they're sometimes called, groups in this country, they stand for white supremacy in response to a growingly multiracial population. So those are real issues. We are not the only country with heterogeneous population. It is a rising and major issue in Europe. It is a cause of major political confrontation, violence, and all the rest of it, which we have no monopoly on by any means. In fact, in many ways, we're lagging behind some of the European countries which have their earlier history of fascism and Nazism and genocide to call upon. It's not a proud heritage, but it's a heritage. So I'm not sure that that factor really works either. And when we start looking at, I've taken off third-party papers, it's logically irrelevant, I think. I've added heterogeneous populations, but I've already done something with it to indicate that it's not a real explanation that could account for the U.S.'s profound difference, really dramatic difference in how it compares to other countries. So I separate, I'm going to go through this list and distinguish between what I call consoling explanations and what I'll call, for simplicity, real explanations. Those that really will help us address the question of why the United States is so different. Consoling means we console ourselves. We feel better about it. We tell ourselves a story that this must be the factor, or this must be an important factor, if not the only factor. And by consoling ourselves and feeling comfortable with that, we avoid the pain and avoid the political difficulty of looking at what are the real explanations. I'll call them real or residual, because my tactic is going to be, I'm going to go through the explanations and I'm going to focus first on what I call the consoling explanations, give you just a sketch of an explanation. Every one of my little arguments is going to be very condensed and it can be challenged. But I'm just going to give you some reasons for thinking that these factors which are introduced into this discussion are in fact of two kinds, consoling and that is not fully real. They help us feel better about our situation. They help us avoid looking at the toughest dimensions, and they are not the most basic underlying explanation. So I'll label this a consoling explanation and get to work on some of the others. All right, let's start then, after that, with growth of technology. It is no doubt true that the growth of technology is a contributing factor to healthcare cost escalation internationally, universally. And it is also true, as Shi and Singh point out on page 472, lower right, that's obviously a note to take. To look at Shi and Singh, 472, lower right. I'm not just throwing this out for my own benefit, that's for yours. There's no doubt that the U.S. invests more than, say, Canada and European countries in R&D for further technological development. This is certainly true. Well, that must explain it then. But I want to add that in the United States, R&D, research and development, is driven by a prospect of profit. Not efficiency, of profit. How can we make something that's bigger, glitzier, more expensive, has more bells and whistles, and may not necessarily do the job any better than an earlier version of that technology, because there's profit to be had in those bells and whistles and whiz-bangs and other things because people pay for it, or, as we'll see, insurance companies are colluding with hospitals and so on to have it paid for. In fact, to make us stop and notice, there are countries, specifically Japan, Austria, and Switzerland, which have, as one measure of technological development and R&D, more MRIs and CT scanners per capita and absolutely than the United States. And yet, their MRI and CT scanner systems are less costly, they're often less cumbersome, they're not such huge apparatuses, they're more portable, they're of different dimensions. Think Japanese brilliant innovations in the 70s of making smaller, more efficient cars when we were lumbering along the road with these gas guzzlers that took up too much room on the highways. And Japan overtook the market. Innovation didn't mean bigger, glitzier. It meant, in that case, smaller, more efficient. And the same thing can be done, has been done, with MRI and CT scanners. They do these things in a much less costly manner. The drive for their R&D is efficiency and making up in volume what they may lose in price point. And you can easily get substantial profit, as car manufacturers, Toyota, etc., have shown, by making smaller, more efficient cars, but selling a lot more of them and driving other cars out of the market. Same thing can be done with medical technology. There's something, in other words, about the structure of profit in the United States, and something about the way medical costs are reimbursed in the United States, not by third-party mechanisms in general, but by something else that's going on that really seems the key in the technology area. So I'm going to label the growth of technology as another consoling explanation. Something that, when we point to, makes us feel better, but doesn't really do the job. It doesn't really explain what's peculiar about the U.S. Let's turn to another factor, the increase in the elderly population. This is discussed by Shi and Singh on pages 473 to 474. It is certainly true that demographically our population is aging. There are more people in the upper age brackets as a proportion of the overall population than before. The numbers, the people are living longer. What was once considered old, 65, 75, in that range, is now considered young old, and people get to be in the old category when they hit the ages, and so on. That's very consoling to me because I'm 75, so I feel pretty young. Anyway, I would have been over the hill and probably dead if I were raised a generation or two ago. It certainly happened to my parents. My mother somehow lived on to 94, but she was stubborn about most things. Anyway. Yet, though this is true about our population, if you look at European populations, you look at the Japanese population, for example, you'll find that those populations have already shifted even more dramatically than the United States is beginning to into the elderly range. There is a much higher percentage of the elderly in many of those countries. And yet, their costs, overall healthcare expenditures, are not the same outrageously increasing nature as the United States. They have somehow found a way to deal with the extra costs of the elderly. They get sick more often, they're sick of more serious illnesses, they require different kinds of care. They have somehow managed to factor that in, and their system can accommodate that. So the mere fact that we have an elderly population can't possibly be anything other than a consoling explanation. It will not account for the uniqueness of the U.S. situation. Another factor that Shi and Singh introduced, I'm going through these rapidly, but in every case I'm giving you pages, get to you in just a second, in Shi and Singh where you can follow. Yes, you had a question.
So do those countries have physically larger elderly populations?
It's not physically, it's the proportion of the population that's the relevant factor. It's not the absolute number, it's the proportion. Okay? Then to move on to another factor that Shi and Singh talk about, which is the medical model of healthcare delivery, which they discuss on 474. We don't emphasize prevention, we don't emphasize public health. What instead we emphasize is treatment of sickness. As I said, I think in one of the very first lectures in the course, that we really don't have a health system at all. We have a sickness system, or we have a medical care system, if you look at it truly. And the two major examples that Shi and Singh use to explain why we can develop such significant costs by not dealing in a preventive way are cigarette smoking and obesity. We have a lot of people who suffer from all kinds of cardiovascular cancers because of smoking, and we have all sorts of people who suffer from diabetes and cardiovascular complications and so on from obesity. Okay, but if we put this again in the comparative international perspective, I think we can understand that both cigarette smoking and obesity are by no means, just like the elderly, unique to the United States, nor even do we lead in the behavior that's supposed to be problematic in the United States. Cigarette smoking is more common elsewhere. It's more common in Europe, and there are literal massive epidemics of smoking now in China and in India. They are not unrelated to the global tobacco companies that realized that the market in the United States was getting smaller because our regulations were getting stricter when we finally took on tobacco about 40 or 50 years down the road in the 1990s. And we made it tougher to recruit new smokers. We made it tougher for people to smoke comfortably because of all the policy interventions, the environmental interventions. So what did those companies do? They didn't give up trying to sell people poison sticks. They sold them to other people. They began huge marketing campaigns in China and India, and they have these vast billion per country populations to sell cigarettes and their dangers to, and they're doing it. As far as obesity is concerned, all you have to do is go to the WHO website. That's easy, who.int, and you will be able to search for any topic you're interested in about obesity. Obesity is now considered, declared by the WHO and various of its committees and special commissions, as a worldwide epidemic. It's not just a problem in the United States, it's a problem in the wealthier of the countries in the global south, such as Brazil is facing a major obesity epidemic and all that goes with it, and even in sub-Saharan Africa there are indications that there are growing problems of obesity and health issues related to that. So again, these factors of having a focus on taking care of things after they develop in the medical model rather than trying to prevent them and developing effective strategic interventions to prevent things before they happen and have negative health consequences is again a broad international phenomenon. And if we look at that to explain the U.S.'s unique costliness, it turns out to wash away as a mere consoling explanation. Yeah, we feel better about ourselves, but it really disappears on close examination. Let me quickly go through two others. One is defensive medicine, or wait, did I leave that off the list? Should be there. Waste and abuse. All right, I should have put that on. Oh no, it's waste and abuse up there. Okay. Shi and Singh talk about this, pages 474, 475 to 476. And the fact is, as we all know, that many physicians engage in extra tests and do extra procedures and spend more time and attention because they are afraid that they'll miss something. They might be subject to malpractice litigation. Those are important issues, but they are issues of there's waste and abuse of procedures that seem to be unnecessary that occur in every country. The basic issue here, and I'll just give you my conclusion, which I think is completely consistent with Shi and Singh, is yes, it's a factor. But if you look at the actual dimensions of it, how much money, it's very hard to estimate when you look at a list of procedures, how many of these procedures were actually needed and indicated by the circumstances, how many were excessive procedures that were added on to give the physician protection or reassurance against possible malpractice litigation. It's hard to say. There are some very clever investigators, it's a good topic for term paper, who have tried to sort that out, some persuasively, some less persuasively. There's a whole huge body of literature about this, but the overall conclusion is that even if you can identify costs which are really unnecessary, wasteful, defensive procedures to protect physicians and hospitals, the actual amount of money that's spent or wasted on that is rather small compared to the overall costs and discrepancies in the health systems, and especially in the U.S. health system. There's a number, it's real, but it's smaller comparatively than you think. So I would call that also a consoling explanation. One more item, practice variations, which are sometimes abbreviated as SAVs, which stand for small area variations. There's an interesting discussion about this, or at least beginning of a discussion, in Shi and Singh on page 476. The essence of small area variations, or practice variations, is this. It's a real phenomenon of physician behavior. That if you actually look at one procedure, let's say tonsillectomies, or prostatectomies, removal of the prostate gland, the part of the prostate gland because of fear of enlargement, which might be cancerous, or might be benign, anyway. And there are ways of dealing with enlarged prostates by medication rather than by surgery. So the prostatectomy, tonsillectomy, if you look at various communities in the U.S., you can find communities which are very small distances apart geographically, maybe 10, 20 miles. And yet they have enormous variation in the rate of the procedure, let's say prostatectomies. Or one town in Vermont, which has been studied, has a very significant number of prostatectomies, and another town in Vermont that seems to have the same demographic structure, same distribution of population, doesn't look any different by any kind of measure, has a much lower rate of prostatectomies and a much higher rate of medical treatment for enlarged prostate hyperplasia. Okay? Why? No one's been able to figure this out. It's been a phenomenon. It's a discovery. And the man who seems to have done most to bring it to our attention, a guy called John Wenberg, who has been a professor for many years at Dartmouth Medical School, has made this a major area of research and study and has become world famous as a center that studies SAVs, small area variations. And the best explanation that he and his colleagues can come up with is that there are subtly different medical cultures in different areas. So let's say town A in Vermont has a medical culture by the senior who do medicine in that culture of doing the surgical procedure for enlarged prostate. And another town, town B, has a long-established medical culture of not doing the surgical procedure, but instead treating with medication. New young physicians are recruited into the town, older ones retire, new ones come in, and the theory is that the new ones are socialized into the mores, the microculture of that town, and they are told when they have consultations with colleagues, when they meet them for lunch, when they're on the golf links, whatever, we don't do much surgery here, we treat medically. And the new young physician says, oh yeah, right. And modifies their behavior accordingly. That's the theory. What we know for a fact is that these small area variations occur everywhere. They make no real rational sense, and they leave us with a central enigma in medical care. Because when you see the same diagnosis leading to two different procedural interventions, one far more costly than the other, the surgical being more costly, of course, than the medical treatment, there is no way of knowing whether there are too many surgeries or too little surgery, whether there's too much medication or too little medication. All we know that there are differences in response to the same basic medical condition. Small area variations is a statement of a phenomenon, and the perception is, if we can figure this out, we will realize that far more than needed of certain expensive procedures are being performed, and if we can figure that out, then we'd have a key to helping solve a major problem of cost escalation and excessive expenditure. We just don't know which is the right standard. Too little, too much, we don't know difference. If we can keep working on this, get more data, then we'll figure it out, and then we'll save bundles and bundles of money. Okay? But here's the thing. Small area variations, as Shi and Singh mentioned in passing on page 476, are universal phenomena. Even in much more tightly overseen and regulated medical systems like England, like France, like Germany, and so on, small area variations occur, as they do in the United States. In fact, the very phenomenon of small area variations was discovered in England and was worked out by English epidemiologists and health service researchers before there was a name for the field in the 1930s and 40s. The man who helped found the field in the United States, whose name I mentioned last time, Carl White, who was Wenberg's teacher, at Johns Hopkins in the late 60s, when that pioneering program in health services research was really getting going. Carl White observed these small area variations, and during a sabbatical leave before he came to Hopkins, he had left University of North Carolina in Chapel Hill and moved to Hopkins. In the interim between one institution and the other, he spent a sabbatical year in England and learned a great deal and was fascinated by the small area variations that English epidemiologists were investigating. So that's just one indication that this is not a uniquely American phenomenon. Small area variations occur in every known health system, and they are particularly dominant in the English system, which is much better overseen in many ways than the United States. So I would say that small area variations also are a consoling explanation. So what's left? By a process of elimination, you'll notice that there are two factors left, which I would label here as are the real or the residual factors that we really need to concentrate on in the U.S. to understand why the U.S. system is such an outlier in terms of cost. Let's deal with the imperfect market first. Imperfect market means, as Shi and Singh point out in the upper right, page 472, that we don't really have a transparent set of prices for procedures. We have really instead a lot of opaqueness. We don't have true competition on the basis of price and quality. We have instead a very strange mix in the United States, which is stranger than anywhere else in the world and is rather difficult. So we can look, for example, on page Shi and Singh 472 upper right, and what they say is prices charged by providers for healthcare services are likely to be much closer to the cost of actually producing their services in a highly regulated or highly competitive market. That is, how much does it really cost to produce the service? Okay, here's a little bit more than we'll charge so we can have a little bit profit or administrative cost. If we had a transparent market that was either highly regulated, that's one way of doing it, or really highly competitive so people could understand what they were paying for, then we would have a much greater set of competition, and people would be making choices based on presumably rational criteria of money for quality and so on. But because they continue, the U.S. healthcare delivery system follows neither the highly regulated single-payer model nor a free market model. Utilization remains largely unchecked. Prices charged for healthcare services remain higher than the true economic cost of production. Prices remain higher because of the opaqueness of the U.S. market. This came out a little bit in the exchange that you and I don't know your name? Thomas and I had at the end of last lecture. This is that same issue picked up again and that we're going to be looking at more directly. I cited a few examples. There are lots of exposés and angry stories in all kinds of newspapers and magazines. And one of these reported, for example, some outrageous kinds of Tylenol in a hospital cost $15 per pill. That's not the cost of Tylenol. That was the charge, and it was paid by the insurer. A box of tissues, this example really gets to me, cost $8. How much did it cost? 23 cents, whatever, depending on the large packet of tissues you buy. And not only that, when you look closely at the hospital bill, where there was an $8 charge for a box of tissues, they weren't called tissues. Get this. They were called a mucus recovery system. Funny, but angering. Right? A mucus recovery system. A damn tissue. Okay. A plastic cup, those little tiny plastic cups to hold a pill. The 2 pills you're given, take this at 8 o'clock in the morning, whatever, the nurse comes by, here's your glass of water. You can buy, I know, because over the summer I bought a big stack like that because my wife wanted to portion her pills for herself. I didn't quite trust the nursing staff. It's another issue. We'll get into that. Anyway, those, buy a stack like that, I don't know, you get what I paid, $3 for 100. On this particular hospital bill, each cup, $10. That's just an indication of what gets put into the hospital bill that most people cannot understand and that gets paid for, by and large, with some negotiation by insurers. There is a big picture story about all this, and it is a very, very frightening story. A wonderful, awarded, respected investigative journalist by the name of Stephen Brill published a book in 2015. The book was called America's Bitter Pill. America's Bitter Pill, 2015. It was reviewed in Lancet, which is generally regarded as the world's most respected medical journal, published in Great Britain. Here's what the reviewer in Lancet said about Brill's book. Pricing by American hospitals starts from something called the charge master that catalogs often outrageous prices for each item and service. Room charges run up to $1,000 a day. Aspirins cost, etc., X times the supermarket rate. Patients who have insurance who are 65 or older and are covered by Medicare do not pay these prices because their insurers receive heavy discounts, with each insurer negotiating its own secret prices with each provider, starting with the charge master price and trying to work the way down. But the real issue, as Brill makes very clear, is where the hell does this charge master price come from? And give me any reason to believe that this whole system isn't a giant scam, not a transparent market reflecting the real cost of production or delivery of services. Patients without insurance are billed the charge master prices, and many will find themselves set upon by collection agencies who, if not paid, will destroy their credit ratings and pursue them to the grave. And the highest prices are therefore charged to the poorest and most vulnerable people, which is an outrage, but it's the case. That book came out in 2015. I'm going to have to stop, and I'll start with this. In 2013, in the March 4th issue of Time magazine, Brill was given the entire issue of Time magazine devoted to a summary of the findings he was coming up with and would publish a year or two later in his book. This Time magazine article, you should look up, March 4th, 2013, Time magazine, Brill, Why Medical Bills Are Killing Us. And we will start with that next time, which will be a week from today, since there's no lecture on Monday for spring break. I mean, fall break. Fall break.